Good day. My name is Paul Wax. I'm the executive director of the American College of Medical Toxicology, and I'd like to welcome you to our weekly webinar series entitled The Medical and Public Health Considerations of COVID-19. Today, we have a very special presentation on children and school in the context of COVID-19. Next slide. I'd like to thank our webinar series partners for helping to get out the word about our weekly webinar series. Next slide. This webinar will be recorded and put on to the ACMT COVID response website by Friday. All the participants will get a notification by email once it's posted. We also have developed a webinar Q&A on many of our webinars, which is also on our website. And any particular questions about this webinar series can be directed to us at webinars@acmt.net. Next slide. We'll be having a QA during the latter part of the webinar today, and we encourage you to participate. You can write in your questions into the Q&A box or the chat box on the Zoom platform, or for those of you on YouTube, you can chat in questions on YouTube. Next slide. I'd like to thank my co-moderator, Dr. Ziad Kazi. Dr. Kazi and I started this webinar series back in March, never imagining that we'd continue this webinar series on a weekly basis, and it's already November. On a personal note, COVID certainly has affected so many of us, and clearly reached out to our families as well. And Dr. Kazi's elderly parents were recently diagnosed with COVID, and his brother, and we wish them a speedy recovery. Next slide. It's my privilege to introduce our guest moderator, who will also introduce our featured speaker today. Dr. Erica Liebelt is a past president of the American College of Medical Toxicology. She's the executive and medical director of the Washington Poison Center in Seattle, Washington, and she's a clinical professor of pediatrics and internal medicine at the University of Washington School of Medicine. Thank you, Erica, for agreeing to moderate, and I'll turn it over to you.
Good afternoon. It's a pleasure to be the guest moderator today for this very, very important webinar topic, as I'm a pediatrician. It gives me great honor and privilege to introduce Dr. Sarah Sally Goza. Dr. Goza began her one-year term as president of the American Academy of Pediatrics on January 1st of 2020. She's a general pediatrician and has had the privilege of taking care of children in her hometown of Fayetteville, Georgia for over 30 years. She is a managing partner in First Georgia Physicians Group. After graduating from Rhodes College, Dr. Goza attended the Medical College of Georgia for her medical degree. Her internship and residency were at Cincinnati Children's Hospital, and Dr. Goza was actually one of my senior residents when I was a medical student, and greatly inspired me. She is on the Community Physicians Advisory Board for Children's Healthcare of Atlanta. She's been involved with the AAP Georgia chapter for over 20 years, serving on multiple committees, the board of directors, and as chapter president. She was on the National Nominating Committee and District 10 representative to the board, and again, in charge of many, many AAP committees. Dr. Goza was involved in the Hub and Spoke Quality Improvement Initiative in the development of the current AAP strategic plan. She represented the Academy at the Council for Medical Specialty Societies. Dr. Goza is very active in her community, having served on the boards for the Girl Scouts, Promise Place for domestic violence, and the Joseph Sam School for children with special needs. Again, it gives me great pleasure to introduce Dr. Goza for today's webinar.
Thank you, Dr. Liebelt. It's good to be here today, you guys, and good afternoon, everyone. Thank you for inviting me to speak today, and thank you for all you do to help keep us all safe. Almost 9 months ago, our lives and our way of life changed dramatically. Who would have thought that we'd look back at 2019 as the good old days or refer to them as simpler times? This pandemic has presented challenges unlike anything most of us have ever seen. Physicians like all of you have risen to the occasion to bring hope and light to a nation sorely in need of both. There is still so much we don't know about the COVID-19 virus and so much learning to be done. But I'd like to share with you today what we do know about children and COVID-19 and what we're doing to keep them and our communities safe. Thankfully, children are spared the most dire consequences, but they can be infected, symptomatic, hospitalized, and transmit the disease to others. And as the virus is settling in for the winter, it appears we will continue to see it in our communities and around the world for a while. See if I can move the slide here. Okay. So let's begin by grounding ourselves in the case data our research department collects from state health departments. This data has become the gold standard for understanding the impacts of COVID-19 on children. Since the onset of the pandemic up until October 29th, there's been a cumulative total of 853,635 child COVID-19 cases reported. Children represented 11% of all cases for an overall rate of 1,134 cases per 100,000 children. There were nearly 200,000 new cases in children just during the month of October. In the 1 week period ending October 29th, there were 61,000 new cases, a larger increase than in any previous week of the pandemic. We believe this number is likely an undercount because children's symptoms are often mild and they may not be tested for every illness. Okay. On every measure, we're headed in the wrong direction. Oops, I went too far. The surge in COVID-19 cases across the country is impacting children at unprecedented levels and is reflective of a disturbing increase in cases throughout most of the United States and all populations, especially among young adults. At this time, severe illness due to COVID-19 appears to be rare among children. However, there's an urgent need to collect more data on longer-term impacts, including its physical, emotional, and mental health effects. All right, I'm having trouble with the slides here, guys. I don't know where I've lost my mouse. Can I get somebody to move my slides for me? I'm having trouble with them. So I'll go to the next one. One more. The biggest spikes we're seeing are in the Midwest, up 21% in the last 2 weeks. Cases in the Northeast are up about 18%, but the most cases are found in the South, nearly 329,000 cases. This virus is highly contagious, and as we see spikes in many communities, children are more likely to be infected too. As we entered a heightened wave of infections around the country, we encourage family holiday gatherings be avoided if possible, especially if there are high-risk individuals in the household. And we urge everyone to do their part to protect healthcare workers in our communities by wearing your mask, practicing physical distancing, and getting your flu shot. Race and ethnicity data is limited and is often not collected or reported, but in 2 of the highly populous states that do report, there's an especially high impact on Hispanic children. While Latino children make up 48% of the child population in California, as you can see on the slide, they make up 73% of COVID cases. In Illinois, Latino children make up 25% of the population and 39% of COVID cases. Experts say this is due in part to close contact with essential workers and crowded living conditions. And Black children also fare worse than other racial groups. So I'm gonna go to the next slide. When it comes to a possible connection between COVID-19 and a rare but serious health condition in children called multisystem inflammatory syndrome, or MISC, there are also disparities. As of mid-October, we had 1,097 US children have contracted MISC and 20 had died. Most cases have been among the Hispanic, Latino, and Black children, 41% of the Hispanic Latino children and 35% of Black children. Just 14% of those who contracted MISC were white. Most cases have occurred in children ages 1 to 14 with an average age of 8. 98% of these cases tested positive for SARS-CoV-2. 2% were around someone with COVID-19. We've been reassuring parents that very few children get severely ill from the virus that causes COVID-19. And so far, most children who have been diagnosed with MIS-C have recovered after getting medical care. Next slide. So it's clear COVID-19 is not having equitable impacts on all the members of our communities. We are still getting a full picture, and race and ethnicity data is limited, but indicators and case examples show that states with surging cases also have higher uninsured rates. And as bad as the data looks for Latino families, it is likely undercounted. COVID-19 has disproportionate health and economic impacts on underserved communities of color, and it's reasonable to expect that mental health impacts will be similar. So I'm gonna go to the next slide. The pandemic has transformed children's lives at critical stages of development and education. While we are just starting to see the true effects of the pandemic, we are seeing evidence that there's significant mental health impact on children and adolescents. Most pediatricians, myself included, report seeing an increase in acuity of illness and more visits for anxiety-related concerns. We know that children and families face many pre-existing environmental stresses. For many, if not all families, COVID has introduced additional stresses, some of which are quite overwhelming as a result of necessary public health measures, such as the isolation. Also, academic impact includes not just the loss of routine, but the loss of actual learning and the impact that can have on the long term, particularly for groups who cannot as easily access virtual learning because they don't have internet or computers, or have learning needs that strongly benefit from an in-person instruction. Economic impact on families, which may increase resource insecurity and anxiety, also are a big problem, and grief and fear for families directly impacted by COVID-19 in some way. We also know that healthcare providers and essential workers may have additional risk and stresses associated with going to their jobs every day, and especially in their children. So the next slide. The pandemic has exacerbated persistent racial and social inequities in educational systems, including disparities in school funding, quality of school buildings, resources for curriculum and teachers, social services, food security, and physical activity. There's a disproportionate impact on English language learners, children with disabilities, children living in poverty, and children and adolescents and families of African American, Latinx, and Native American Alaska Native origin. We have to provide adequate resources for schools and families to access the support services that they need. Next slide. This past March, schools across the country closed their buildings and canceled in-person classes to contain the spread of SARS-CoV-2. In early summer, the AAP issued its first guidance on the safe reopening of schools, which we've updated about every 30 days. The importance of in-person learning is well documented, and there's already evidence of the negative impact school closures had on children last spring. That's because children who are in school receive so much more than academic instruction. I like to say it's more than reading, writing, and arithmetic. Schools help develop social and emotional skills, provide healthy, reliable meals, offer physical, speech, and mental health therapy, as well as physical activity. Lengthy time away from school deprives students of these benefits and makes it hard to identify and address important learning deficits, as well as physical abuse, sexual abuse, substance use, depression, and suicidal ideation. Beyond the educational and social impacts of school closures and distance learning, there's been substantial impact on food security and physical activity for children and families. We know pre-pandemic 1 in 6 children were food insecure, and we now know that's down to 1 to 4 children are food insecure. So next slide. This next slide, on July 7th, I took part in a White House panel and roundtable comprised of educators, students, and school and public health officials about safely reopening our schools. You'll see me sitting there. I have the mask on. I did take it off to talk, but I put it right back on. I was one of about 2 people in the entire room that kept their mask on, except for the press. The press did have their mask on. The clear message we sent and continue to send to our nation's leaders are that school is important for child health. We must develop strategies that can be revised based on COVID transmission in the school and community. And they need to be formed in collaboration with state and local public health authorities. And they have to recognize the differences between school populations in urban, suburban, and rural areas. These policies have to be feasible and appropriate for students' development and reflect the differential impact that this virus has had on different races and vulnerable populations. And in order to have students in the classroom, the plan has to be flexible, guided by science, and focused on the needs of children and the community. And on top of all that, we have to have our federal government put new investments in our schools and campuses. So next slide, please. This slide's a little busy. It's the CDC decision-making tool. As far as advising parents and families on whether in-person learning is right for their child, physicians can really do a lot to help this. I've had a lot of conversations and virtual visits with families talking about what's going to be best for their children. A thorough and balanced understanding of the known benefits and risk of in-person attendance, virtual learning, and hybrid models is really important. The CDC decision-making tool you see can be at the starting point for that discussion. It can be found on the CDC website. With virtual instruction, hybrid or full, schools should really arrange access to adequate internet bandwidth, which I don't even have in my house, which I have DSL still here because I live way out in the country. We need connection speeds that work, individual devices for instruction, and then training for families on the use of these, particularly those with less digital fluency. IEPs and 504 plans to accommodate virtual and hybrid instruction methods need to be updated and they need to prioritize the goals and 5 creative and flexible approaches to achieve such goals. They need to provide options for aides in person at home or virtual or home nursing to assist those children with special healthcare needs with virtual learning. And if you have a child with special healthcare needs or a family member who would be at high risk, we need to allow people to do virtual learning if they need to, instead of being in person where they could have the risk of this virus. We need services once children get back into in-person instruction to catch kids up. We need to allow those choosing virtual learning to participate in some in-person activities, therapies, outdoor events on an individualized basis. And we have to have options for food delivery for those those families who are food insecure. So those children don't go hungry, because you can't learn if you're hungry. We need to support additional mental and behavioral health needs of students and staff. We know that's a big issue now, and that's going to require more people in the schools to be able to do that, and funding. We need to make sure that children and adolescents who may be at high risk for COVID-19 can be in activities which are in larger, better ventilated and less crowded indoor spaces or outdoor spaces with attention to PPE, surface cleaning, and hand hygiene. So I'm gonna go to the next slide. So these are the slides we have about our own school guidance that we put out. I'm gonna quickly go over them. This is about physical distancing. 6 feet is the recommended space. Some places have opened with 3 feet with people wearing masks. I think there's still a lot of debate about whether 6 feet is even far enough. Face coverings are mandatory in some jurisdictions, they're not in others. We do feel like that children should be wearing face masks. We think teachers and staff also need to have that physical distancing. They need to avoid the teachers' lounges and other places they may gather and do their faculty meetings virtually, because we know the spread between adults is more likely than the spread between children. Next slide. So this is our slide about face coverings or masks. They're important. We initially said that all children should try to wear them if they're over the age of 2. We came back out later and said all children 2 and above should be able to wear face masks, and that teachers and staff should wear them as well as the students. We know this can help slow the spread of this disease. I know people say their children won't wear face masks, but I have been amazed in my office at the kids rocking their mask. They keep those masks on, they don't touch them. They are actually, when I pull them down to look in their mouth, they're almost like a little surprised that I'm even going to pull them down and touch them. The parents have a much harder time wearing the mask sometimes than the kids do. And if you have all the kids in a classroom wearing masks, they're not going to complain about it. They don't want to be different. So it's doable, and we need to try to encourage children over the 2 and above to wear face masks. Next slide. So these are some of our special physical distancing issues on buses. We recommend assigned seating with spacing, mask wearing by everybody on the bus, physical barrier for the bus driver, trying to have smaller numbers of kids on the bus, so cohorting those kids as well. Hallways, really strategies to reduce traffic in the hallways. You can have the teachers change classes rather than students, have classes that are cohorted together, change classes at the same time so they're spaced out and there are not as many people in the hallway. And a lot of places have gone to one-way traffic in hallways. I know they've done that at grocery store too, and I'm not so good at it, so I don't know how that works in the schools, but it can be done. In the cafeterias, reimagine where students eat. They can eat outside if the weather's nice. Now it's getting cold, so that won't happen in a lot of places. Eat in the classrooms or stagger lunches. You don't have to have everybody in there at the same time. Stagger it so you can keep cohorts together and have extra spacing in the cafeterias as well. And then playgrounds, again, try not to have everybody out on the playground at the same time, cohorting the groups on the playground, limiting those numbers, and making sure we clean the equipment out on the playground. So next slide. On cleaning, and the cleaning is mainly frequent hand washing, which we all know we need to do. Reducing those high touch surfaces as much as possible and cleaning them if you can't reduce them. And that includes the outdoor spaces. So next slide. Lots been said about screening kids with symptom checking and temperature screening. We know that can be difficult and not necessarily feasible. A lot of places are doing it. A lot of places are also having the parents do it at home and send it into the school or for the kids getting on the buses. So that can work as well. Parents should be encouraged to keep their children home when they're sick. We've always said, if it's just a little runny nose, send them to school. At this point in time, if your child is sick, they're not feeling good, you should keep them home. And we need to really encourage our parents that that's the best thing to do. Testing for COVID prior to school entry may be really misleading. As we all know, you may be test negative one day and then test positive in subsequent days. It's really hard to know how that really day you test means you're not positive that day. It doesn't mean anything for the next day. And if there is exposure or symptoms, we are encouraging parents and families and to call their pediatrician and discuss what they need to do. Quarantining, testing, all of those things. So the next slide. This is just a quick slide on hearing and vision screening that we feel like children still need to be screened for this, at least yearly, to make sure that we're not missing children who may need some accommodations for hearing and vision issues. So the next slide. Schools should train educators on how to talk and support children and refer those who require mental health support to the professionals. Special considerations are warranted for students with pre-existing anxiety, depression, and other mental health conditions. We're seeing a lot of kids who had baseline anxiety that wasn't so overwhelming, but now with COVID and the isolation, we're seeing it really escalate to the point where we're having to do a lot of therapy and treatment. Students facing poverty, food insecurity, homelessness, who are subjected to ongoing racial inequities can benefit from additional support and assistance. And this is all going to require additional funding to ensure adequate staff and training for that. We need to meet these kids where they are when they get back into school, rather than expecting them just to jump in and be right where they were when they left. There's been a lot of loss of some of the educational stuff and also the emotional stuff. You may have a child going back to school who's lost loved ones to COVID. And so that's a big stressor. And if we don't know about it and can't help them with that, then we're not going to be doing them any favors. So next slide. For children with medical complexity, we must plan and plan again. The patient, the family, the medical and school team need to communicate and develop a plan really based on currently available information that's in the best interest of that child and their family circumstances. And these can be all over the place. There could be where it's better to be hybrid, where it's better to be in person, whether it's better to be online, but try to really make sure that you're making those plans in consultation with all the people involved. And you have to be ready to adapt and change, because that plan could change as soon as new information becomes available. Next slide. Children are going to likely miss school this year more than usual. We're already seeing it due to symptoms of COVID. We get calls all the time that they get sent home from school and the parents are like, when can we take them back? And so you're having to deal with all that. If you look on the right side there, they're the COVID symptoms. This is what we see in a pediatric. This is bread and butter pediatrics: fever, chills, cough, shortness of breath, rash, nasal congestion, runny nose, all of the nausea, vomiting, loss of taste and smell is a little different. We know that's probably COVID if they have that, but headaches and myalgia, all of those things are what we see in pediatrics during respiratory season all the time. And so they're very non-specific. And so it's going to be really hard. Pediatricians are really struggling on how to clear patients for return to school. We're learning more every day. We're getting more guidelines, and they're changing as we learn more about the virus and how it spreads between children. But we are recommending testing for known exposures or symptomatic children. What we know about testing, and I think I saw where y'all are have a webinar on testing, is that if you test an asymptomatic child, it really needs to be at the right time. You don't want to do it too early because the rapid test is not going to be as accurate for that as the PCR. For symptomatic children, the rapid or the PCR sometimes is good. So I think you have to look at that. And we get a lot of calls where we're talking to parents about they've been exposed and quarantining for 14 days. If and when they should go get tests, what to look for their kids to be symptomatic. And and it's very confusing for parents. It's confusing for our staff. We as the pediatricians are now pretty much getting on the phone with those parents and talking, because it's really hard to know. You have to find out exactly when they were exposed, who they're exposed, all of those things. It's very interesting. Some places, some schools have different rules for when you have to quarantine, when you can go back to school. So it's very interesting too, if you work in an area where there are a lot of different school systems, to figure out what they're telling the parents as well as what you're telling them, so you're all on the same page. Next slide. So this is our CDC guidance for return to school. And these are the bullet points with this, though it can vary. So it's a pediatrician confirmed alternative diagnosis and afebrile for 3 days without fever, without Tylenol or Motrin. Or you can have if you're sick, 3 days without fever reducing medicines, respiratory symptoms have improved, and it's 10 days since your symptoms started, at least 10 days. Or 10 days after a positive test if you're asymptomatic. Or for those people who may not get tested but have been exposed to someone with a positive test, it's 14 days after exposure. Next slide. So these are just some of the other guidances that we have. We have the emotional and behavior. I'll talk about that one in a minute. We have family presence policies for pediatric inpatient settings, newborn screening, frequently asked questions about transporting patients, COVID-19 testing guidance, PPE for pediatric care, return to sports. We also have some on all different things. We have it about how to take care of newborns, mothers of COVID positive mothers, also we're coming out with a update on our about get children coming into the office and how to see them in the office and things like that. Most recently, the one we is the interim guidance on supporting the emotional and behavioral health needs of children, adolescents, and families during the pandemic. So I'm going to go to the next slide. So emotional and behavioral health challenges were of growing concern before the COVID-19 pandemic. We've been seeing increases in depression and suicide ideation and all of that for the last 5 to 10 years. And so, but this public health emergency has really exacerbated those challenges. We're seeing it more and more. The pandemic continues to highlight many factors that make life more challenging and stressful for many during this time. And our kids are really feeling the burden because their lives have just been upended completely. So next slide. The frame around our guidance for this is that many children with special healthcare needs are likely to have adverse effects from the pandemic disruption to healthcare, education, childcare, and community life, while a subset is more likely to have severe biological effects. And we have to use the best evidence to reduce risk of infection spread as much as possible, but also advocate for the accommodations needed for these children to get their needs for education, healthcare, childcare, and community living met safely during the pandemic. So I'm going to go to the next slide. Just like you guys, we're not doing it every week, but we have bi-weekly live video conferences so pediatricians and other health professionals can learn more about COVID-19 from AAP experts. It's great. We have our infectious disease people on there. We have people out in the field doing the care. And the guidance that I just talked about will be discussed at tomorrow evening's town hall, which you can access through aap.org, or they are recorded so you can listen to them after they're recorded. And we would, you're all welcome to join us. So next slide. Finally, I'd like to tell you a little bit about what we're doing regarding COVID-19 in terms of advocacy. With the country roughly 8 months into the response to the coronavirus, the AAP continues to advocate at the federal and state level to ensure the government response adequately addresses the needs of children, families, and pediatricians. So I'm going to go to the next slide. Among our top priorities are to stabilize healthcare delivery for children by addressing financial hardship among physician practices and ensuring pediatricians have access to immediate financial relief that enables them to continue providing care to children. To increase Medicaid funding to ensure children and families can get covered during the crisis, ensure families have access to nutritious foods while the economy recovers, protect global health and U.S. security, provide federal resources to school systems so they are in a position to be able to safely reopen or stay open and educate our nation's children, and increase vaccination confidence to prepare for a future vaccine for COVID-19. The common theme in all this is our call for stronger federal leadership on Medicaid, telehealth, vaccines, testing, and other core components of pediatric care, and ensuring that the response to COVID-19 at all levels of government accounts for children's special needs, including justice-involved youth, children from low-income families, children in the child welfare system, and children in immigrant families. So the next slide, please. In a letter to federal health officials, as well as an open letter in the Wall Street Journal, the AAP urged transparency, scientific rigor, and the inclusion of children in trials for a safe and effective vaccine against the COVID-19 virus to ensure it's embraced not only by the medical providers, but by the public. Next slide. If we're to successfully administer a COVID-19 vaccine when it becomes available, we need to improve vaccine delivery systems and increase confidence in vaccines across this country. We have a problem with that. We've issued recommendations to federal, state, and local governments on how to strengthen the immunization delivery system, as well as the Vaccines for Children program, and we'll continue to work with Congress and the administration to support science and protect our children and communities from vaccine-preventable diseases. So next slide. So I'm gonna switch gears here for my last few comments, and then I see some questions down there. Our new Blueprint for Children was recently released, and it outlines how we will continue to advocate and recommend policies that respond to the moment and promote healthy children, support secure families, build strong communities, and reclaim America's role as a leading nation for youth. Children and adolescents face intersecting crises. This pandemic's consequences for youth far surpass those of the disease itself. Children have lost the institutions that provide structure to and support for their lives, and with mental and physical health consequences that may take decades to unfurl. Children have also suffered the deaths of loved ones from COVID-19 and the loss of critical connections. And meanwhile, racism persists as a public health crisis. Functioning as a social determinant of health, racism plagues children of color with birth disparities, chronic stress, and lifelong mental and physical health problems. Children of color now make up a majority of American youth, so their health and prosperity will determine our nation's future. The persistent dangers of COVID-19 and racism have exacerbated and complicated existing health problems for youth. Studies show all social determinants of health, including housing, healthcare access, educational inequalities, income gaps, occupational hazards, and both unconscious biases and outright discrimination are all stacked against children of color. And our nation can do better than this. We must ensure every child's success. We have to ensure that every child has food, housing, and healthcare, and a loving, supportive environment. And strong communities are the building blocks for secure families and healthy children. So we have to make sure that children are safe in our communities and have equal access to opportunities, regardless of their racial or ethnic background, income, or where they live. So next slide. You can access the entire blueprint on our aap.org website. It has lots of recommended policies ranging from what we need to do for COVID-19 to restoring confidence in our public health and scientific agencies by reinvigorating their independence from political influence, rebuilding their commitment to evidence-based action, and restoring their role as the first line of defense for public health, prioritizing international efforts by working with the World Health Organization, expanding federal funding for pediatric research, and so that we can support the career development of researchers and really have biomedical innovation and development of next generation therapeutics for children. So almost 9 months into this pandemic, what have we learned? I'll leave you with 4 takeaways. First, that this disease is dynamic and our response must be highly adaptable. Second, that the best way to manage the uncertainty is through data and continued collaboration. Data connects us, helps predict the likely course of events, and guides us in determining how best to care for and protect children and families. Third, that the pandemic is having soul-crushing medical, social, and economic consequences for Black and Latinx communities, and we must continue to confront these inequities for the good of all Americans. And finally, as our country struggles through a situation unlike anything we have ever witnessed, with no clear end in sight, it falls to us as physicians and other healthcare workers to shine a light on science, speak up for those with no voice, and ensure America's children and families not only make it through the pandemic, but they have a healthy future on the other side. I'd like to just end with the encouraging words that at some point this pandemic will end. or at least we'll be able to control it with an effective vaccine and therapeutics. In the meantime, please take care of yourself, be kind to yourself, and stay strong and healthy. And now I'll be happy to take your questions.
Thank you so much, Dr. Goza, for that outstanding presentation. We have many questions. And so I'm trying to group them. I'm going to start off. The first one is, do we have any data on the case fatality rate and hospitalization rate of children with acute COVID infection and or those with MIS-C?
The last number I saw of deaths from COVID-19 in children was like 109 or 110. And that's a little bit old, so there may be more than that. Hospitalization rates are still very low, less than 1% in most places. Hospitalizations may be a little bit higher than that. Deaths are less than 1%. So it's still very, very low. So we do know that children are not as affected as dramatically as adults in this. But I mean, we've all heard of children being on ECMO and other things, because the children can get very, very sick with it, but it's rare.
Okay. We have several questions that are pertaining to schools, school closings, and school reopenings. I'd like to ask, do we have any evidence that the uptick in cases is due to school reopenings? And a corollary to that is, what are your thoughts weighing the continuance of hybrid learning versus moving back to full distance learning?
We don't have any data. I mean, that's the bottom line, is the data is not, we know that the numbers have gone up in October. That was when we've had the highest numbers of increases. We don't know if those children are getting the illness at school or if they're getting it from their parents and other young adults who are also getting it. We know that the numbers in communities are going up. And so if the numbers in communities are going up, we know the numbers in children are going to go up. It's interesting that the first increase we saw, especially in the South, was back in the summer. So that was before school started. So we know that gatherings can do this. Children are back in sports as well. I mean, it has to be increasing the numbers to some degree. Whether it's really the main culprit of what's increasing the numbers, we really don't know. And the other question about hybrid versus online versus full in person, I think that is very community related, because if you have a community that doesn't have a lot of spread, you should be able to have your children in-person learning. If it's been there for a long time. If you're in an area where there's increasing numbers, then I think you have to really be careful with that, because we know if those kids are in the classrooms, even with wearing masks and trying to, doing the physical distance, they're still there all day. And so that's going to increase the risk of the transmission if somebody does show up and has the illness. And 40% of people are asymptomatic, and we know children are actually a lot of the asymptomatic carriers of this, so they don't even feel sick. And so that's a hard problem. We need more data. We really need to be working with our schools and the CDC to get that data to see how many children are getting sick at school, and then how many people are the contact tracing to see how many people get it from there. I know I just did a call today with a mother whose child was exposed on the 28th. They didn't tell anybody at the school until the 2nd. Anyway, but then the public health is now doing contact tracing and trying to find out how many of the children in that classroom are going to actually end up getting it. So they're all quarantined now. So there is that going on. It's just hard. We are still struggling to get testing and contact tracing done like we need to do it.
We have an interesting question about vaccines, and our phase 3 vaccine trials. Does the AAP feel, are those adequate to proceed with vaccination of children, or do we need specific trials including children prior to?
We have to have trials that include children. There is no question about it. Children react differently to medicines. They react differently to vaccines. And we are concerned that there may be some special, unique things that can have as related to this illness. MIS-C was first reported in children. Now they're telling me there's an MIS-A, which is in adults. So they are seeing that, but it was first reported in children. And so is that going to make it complicated for a vaccine in children. So yes, we are encouraging them to, as soon as possible, as soon as it's the right time, for the FDA to get children into clinical trials. And I know there is one clinical trial that's going down to age 12 now. So, and then my understanding is it will go lower than that. So we're not really looking for there to be a safe and effective vaccine that's really tested in children until sometime next year.
Okay.
So Dr. Fauci assures me that if we have phase 3 clinical trials in adults, it will be much quicker to get trials in children and get them done. So.
And then we've heard a lot about long haulers and adults with COVID and long-term consequences. And again, has any data emerged about long-term effects in children with acute COVID infection?
I don't know that we have any data saying how many children have that. We are hearing reports of that there are children who are staying ill from this for quite a long time. The cardiologists are very concerned about cardiac effects from this disease. So that hence the return to sports guidance that talks about, what you do to get kids back into sports after they've had COVID. I mean, it's according to whether they're asymptomatic, mild, or severe. And how long they have to, because they have had some cases of myocarditis in children post-COVID. The children with MIS-C, of course, are in a totally different ballgame. They're out for, their return is much longer. So we're following that very closely. Our experts watch it every day. We are trying really hard to get the data reported so that we can gather it. It's very difficult. The children's data goes 0 to 18. It's never been, they haven't really broken it down into smaller age groups. So when you look at all those numbers I gave you are 0 to 18 for the most part. Some are 0 to 17, some, but in general, 0 to 18. And that's a wide range of children. I mean, that's really, well, it doesn't break it down by the age groups we would break it down to.
There's a very interesting question about rapid testing and whether you feel that possibly a home test might be a potential solution to keeping our schools healthy and open. And have you heard of this as a recommendation or as a near possibility in the future?
I have heard of it as a possibility in the future. I think it's like a little credit card or something that they're talking about that you'll be able to do. I don't think it's ready for prime time yet. I think everybody's hopeful that something like that will come out and it'll be mass produced and people can actually really test and then try to quarantine if they are positive and try to slow the spread. I have not heard anything about it recently, to tell you the truth. That was back early in October that I heard about that, and I've not heard anything more about it. But yes, I mean, if we had something like that, I think it would be very helpful.
Right. This is also an interesting question, and you alluded to a corollary of this when you showed the slide about how, as pediatricians, we see some of these common COVID signs and symptoms like every respiratory season, not the loss of taste or smell so often, but it just comes every year. So somebody is asking, why are we handling COVID risk in children different than influenza in children? Why do we not close schools out of fear from flu transmission to parents or other family members?
There's a lot. I mean, there's a little bit of, nugget to that. But the bottom line is we have a vaccine for flu. And so we can vaccinate people for flu and control that spread more. If we had more people getting vaccinated for flu, we would have less flu every year. I mean, that's my plug for everybody to get their flu vaccine if you've not already done it, because we do know that's going to be part of what we have to do with COVID. When we do have a vaccine, that will be part of what we can do to help prevent the spread of COVID. If you look at flu and COVID, I mean, we've only had 9 months of COVID, and you look at the devastation it's caused, it spreads really almost, because it's a new virus and nobody has immunity, it's going to spread more. And so I think that's why it's been handled differently than flu. And like I said, we do have a flu vaccine. We can prevent flu in people that will get the flu vaccine. And when we do get robust flu vaccine seasons, we have less flu in our communities. And so That's why it's probably handled. And I know our school system shut down last year for flu because they had such an outbreak. So I think when there's a big outbreak in the schools do shut down for flu.
One attendee asked, has the American Academy of Pediatrics developed educational materials specifically for children?
Absolutely. Thank you for that one. Go to healthychildren.org. There is so much information on there about COVID-19. I mean, we talk about how do you talk to your kids about this? How do you do this? And there's tons of information there that the kids can read, that the parents can read and share with their children. So yes, every time we put out a guidance, we actually have a corollary for parents of how to talk to your children about the things that we're talking about in our guidance. So it's right there on healthychildren.org. We also, I think there are some webinars on there too, where people have done webinars about different things as well that you could share.
Great.
And it's accessible to anyone that wants to look at it.
Yeah, those are great resources. And again, they're accessible to the public.
Yeah, the other thing is that AAP.org, anything COVID related, there are a couple of things that aren't, but most everything COVID related on AAP.org is in front of the firewall. So you don't have to be a member or have an ID to get to the COVID-19 resources. We did that on purpose so that anyone could access those.
We have another question about MISC. Are there specific underlying health conditions that these children had and any other correlating factors?
We know that a lot of the children who get really sick with COVID-19 do have some underlying conditions. Not all, just like in adults, it's not completely, but a lot of them do. I don't know about the MISC. I don't know the data on that of if they had special healthcare needs. I'm sure some of them did. I know the ones I've had in my practice did not have special healthcare needs. They were just normal, healthy kids who unfortunately got COVID. A lot of them didn't even know they had COVID. They were so mild with their COVID and they just come in really, really sick, which is kind of scary for us to think about. Oh, so it's been very interesting.
This is a pretty hot topic. It relates to sports and children. 2 questions. Please share your thoughts regarding winter high school sports, and then what are recommendations for masks with youth sports in children like soccer and basketball?
So our guidance on masks does talk about sports. And so of course, if you're doing gymnastics or something where the mask could get caught on something, we do not recommend wearing your mask when you're doing the actual physical activity. If it's really strenuous physical activity, we don't recommend wearing your mask. If you're swimming, we don't recommend wearing your mask when you're swimming. But if you're on the sidelines or you're, doing something that's not so strenuous, we do recommend wearing the mask. And so if you're playing soccer and you're on the sidelines, we recommend staying 6 feet apart, wearing the mask. We do recommend that most sports that can be done outside because we know that's better. You don't have as much of a spread. Indoor, we know does increase the risk of spread. I think I could tell you what the guidance is right now. I don't know that we talk about this, how to decide whether that return to sports talks about what's safe in sports, what's not safe, how to gauge all of that. I'm very acutely aware we are going to have some conversations with the increasing numbers that we're seeing over the last month. I think we will go back and re-looking at some of the things that we're recommending and how we're recommending it, just because we are seeing such a surge in children's cases. And so what does that mean? How do we deal with that? Do we change our recommendations? Do we not? Our guidance it's looked at every 30 days, if not earlier. And so some of that may change. It may stay the same. I just don't know yet. We'll have to have our experts really looking at it and giving us expert advice. So that's not a very good answer for you. I don't know what to do about winter sports. I really don't.
Tough.
I feel bad for the kids, but being inside is probably not going to be good in big crowds.
Mm-hmm. Are there any plans to establish a national surveillance system for children with COVID and post-infectious inflammatory consequences, even secondary to asymptomatic COVID-19 infections? And there was another similar question about a national database for children.
Yeah, I don't know that the CDC has done anything like that. Our perinatal section actually has a registry where they're tracking children whose mothers were positive for COVID. So they actually are following those babies. We don't have anything right now, but I will tell you that the American Academy of Pediatrics is launching the child health informational longitudinal data anyway, it's called the child registry, but it's going to be a data registry. We're excited about it. We wish we had it right now, that it was up and running already. We voted to approve that, moving forward with that in May. It's not going to help us this time around. But there will be a data registry the next time we have something like this. Hopefully we will have a data registry where we can track all of that, because it's very important. I mean, if we could track what's going on with kids, I think we would have a lot more information about what's going on with these, because a lot of it's anecdotal right now.
This doesn't have to do with schools, but I actually was asked this question. What about breastfeeding infants whose mothers are COVID positive?
So the data does not show that it crosses through the breast milk. So the recommendation is if the mother wants to breastfeed. We do ask that she wash her hands and that she wears a mask when she's breastfeeding.
Okay, interesting. Okay. There's another comment. What have we learned from Sweden, where schools remained open throughout the last academic year?
You know, we've looked at all of that. Their community spread was not as high as ours. And so therein lies, I mean, because we did look at that when we did our initial school guidance. We thought we can do this. We can make this happen. And then unfortunately we had the big surge in COVID cases again. And so I think, you know, it's one thing to open schools when you have low transmission of COVID in your community. It's another thing when you have high transmission rates in your community. And I think that's why it's so much school system related as to how it's done here in the US, which is good and bad in a lot of ways, because there's no national guidance, but it also is very local, because if you have a community where there's low community spread of COVID, then it is probably feasible to do these things and have schools be open. If you have high rates of community spread, then I think, you know, you're putting people at higher risk, because it's going to spread.
Right. And there was another question similar to sports. What are your recommendations regarding school chorus, bands, band practice, etc.?
You know, we do know that that's more forceful respiration. A lot of the places that are doing that, you know, they're doing amazing, innovative things to try to decrease the spread with that and let kids have their band, to have their chorus. It's hard to do on Zoom. Singing on Zoom is hard when you're trying to teach people how to do all of that. But they're really doing it where they're putting a lot of space between the kids and trying to do it. I don't know that we know enough about how we know that the forceful playing an instrument and singing, if you are infected, spreads the virus more quickly and more effectively. I think it's hard to know what's the right thing to do with that. But I know that the chorus teachers and the band teachers are really working hard on trying to figure out what kind of distance can we put between these kids? Can we do it in groups where we only have part of the kids there, and then and even doing some of it virtually. I have seen some of it virtually.
Yeah, it's been very creative. I have too. Just a couple more questions. One has to do with daycare and sending children to daycare. What are your thoughts about that?
We have guidance on daycare too. It was just redone. So it's actually pretty new. We recommend the same things, smaller teacher to child ratio, cleaning, all of those things. What's been very interesting is in the daycares when they've done the interventions where the mask for the children 2 and above, the physical distancing, washing their hands, all of those things, that the transmission rate in daycares has not been that high. And daycare stayed open even in New York City during the pandemic, when they were having their big surge. And so I think that's a testament to doing the right things, but also probably showing that smaller children are not as likely to spread the disease.
Okay. And this is going to be our,
though, as I laugh and say, more to come.
Yeah. I find that very interesting too about the daycare. Um, our question is about, are you aware of any guidance or guidelines to help parents assess the risk of their child returning to school? For example, how to balance an individual family's risk versus the risk of remaining in remote learning setting for a particular student?
I think that's very critical. And I do a lot of calls about this now because, if you have a child who has ADHD or who has, learning issues or whose parent can't be home with them. I had one today. The mother can't be home with this first grader. And so the older sister's trying to do his first grade work. And I'm like, this is not going to be good. But their school's not open. All they have is virtual right now. So I think you really have to work with talking to the parents and really looking at what's your child's learning. Are they going to be able to sit in front of a screen and learn all day, or are they going to be standing on their head and looking at the cat and, doing, letting the dog, how are you going to handle working with them? If the parent's not very well versed in the educational type of stuff, sometimes that can be very difficult too. What if you don't have broadband? DSL is okay, but it's not great. And, it cuts out and you miss stuff. So, or if you don't have any internet access, you're having to go to to the store, to the restaurant or Arby's or McDonald's or somewhere where they have free Wi-Fi and sit outside to get your internet. So I think there's just all kinds of things that you have to play into that. And there are children who just do not do well with online learning. And we know that, and we are very concerned about the educational gap that this is creating. And so I think you have to weigh that with the risk of being in school, whether being hybrid or being in full-time school. And really it's a balancing act, because you're not going to ever get rid of all the risk. All we can do is mitigate risk. So you've got to figure out how much mitigation do you need to make it safe enough that you feel comfortable doing it. Or if you really can't feel safe doing it, how much can you do with the online? So it's I tell families, it's hard to make that decision sometimes on your own. And so it's nice to bounce it off your pediatrician. And we're happy to do that. That's part of what we do. Yes, we're about the health of your child, but we're also about their emotional health and their behavioral health. And so I think that's all plays into this.
And I think you've stressed that multiple times about how some of these very challenging situations really depend on the community you live in and the individual child, family, parent, caregiver situation, and that it's okay to ask for help and recommendations from other people, because I don't think there's a one cookie cutter answer that's going to apply to every single child in this country or world during this pandemic.
No.
So I really appreciate your perspective on that and the Academy's perspective on that. I believe we're running out of time right now. I need to be respectful of Dr. Goza's very busy schedule. And again, we are so thankful that she was able to speak to us today. This webinar will be recorded. Slides will be available by the end of the week, as we mentioned at the beginning of the webinar. So thank you all very much for your attendance. And thank you again, Dr. Goza, the president of the American Academy of Pediatrics, for your leadership and your expertise.
Thank you so much for having me. By the way, the data is updated every Monday on the AAP.org if anybody wants to look at the data every week.
Okay. Thank you very much.
Bye, everybody.
Yeah, great. And I'd like to just thank Dr. Goza again and Dr. Liebelt for excellent moderation. Really a wonderful talk, and we'll have this up on our website as mentioned in 2 days. Could we put on the last couple of slides, Dia? So our next webinar will be next Wednesday, November 11th at 3 p.m. We're going to be discussing risk communication in unusual times. So a very important topic. And we're also going to have a research update on the media, pandemics, and health behavior. So that's next Wednesday at 3 p.m. Eastern. Next slide. All of our webinars, as mentioned, are up on our website at acmt.net/COVID-19 web, and you can download or you can listen to the full broadcast of the webinar, or you can download actually the slide set as well. Next slide. Some of the additional upcoming webinars later on in the month, including a very important presentation from Tim Urecki, who's the Chief Medical Officer of the Influenza Division at CDC. He's going to be talking about seasonal influenza during the COVID-19 pandemic. On December 9th, we'll continue with the first in a series of webinars on disinfectants. This is going to be on disinfection and sterilization, a primer with a focus on use in healthcare facilities. And finally, the last webinar for this calendar year will be on December 16th, when we have Dr. Denise Jameson, who's the chair of OBGYN at Emory University, and she'll be talking about pregnancy during COVID-19. Next slide. All the information about our past webinars and upcoming webinars can be found on our prospectus, which can be downloaded from our website. At this point, I'd like to thank Dr. Goza again, and Dr. Liebelt, and Dr. Kazi. Everyone have a good day. Thank you.
Bye, everybody.
Bye.
Thanks.